Hello. Let's talk about leiomyomas of the uterus. Leiomyomas are smooth muscle tumors, and leiomyosarcomas are invasive smooth muscle tumors. They're malignant. The uterine has an endothelial lining, and then it's got a thick, smooth muscle layer, and then it's lined by a serosal sort of adventitia, and actually, if you think about it in terms of layers, very similar to the heart, right? You've got an endocardium and a myocardium and an epicardium. So the uterus is kind of doing the same thing. So a leiomyoma or leiomyosarcoma can pop up in any of these three layers, i.e., on the inside of the uterus, on the outside of the uterus, or square in the middle of the smooth muscle of the uterine wall. And so that's called the submucosal fibroid if it's on the inside, and that would be analogous, again, comparing it to the heart, to the endocardium. Or you could have a subserosal fibroid because there's a serosal membrane there, and a serosal membrane is essentially anything with a visceral and a parietal layer and some potential fluid space in between. So the subserosal fibroid is on the outside of the organ. And then you have your intramural fibroid, intra within mural, the wall. That makes a lot of sense. And these fibroid tumors can be pedunculated. And pedunculated means that there's a stalk to it and it's growing as a mass out of a stalk. You could kind of picture it like a water tower of sorts. And so this is worse than if it's just growing in a sessile manner, meaning in place, because when it's pedunculated, there's a lot more room for expansion. It's no longer limited by just the boundaries of the serosa or the endometrium. It is then free to grow into the lumen of the uterus if it's a submucosal fibroid, or outside the uterus and potentially even into the peritoneal cavity if it is a subserosal fibroid on the outside of the organ. So that's vocabulary. Where do I think the questions will come from on this STL? I think we'll get one on the leiomyosarcoma. I think it'll be just make the diagnosis, where there's histology, maybe a gross appearance, and you have to understand the leiomyosarcoma bleeds and hemorrhages and dies. It goes necrotic, and it's got really bad nuclear changes compared to the leiomyoma. Maybe you get a genetics question on the leiomyosarcoma, but there's really nothing in this STL to ask about. The leiomyoma, you're going to get 3 or 4 questions just about leiomyomas if we get 5 from this STL. This is a short one. I would imagine one of the few questions about leiomyomas is probably just going to be, what subtype of leiomyoma is this, submucosal or intramural? And I would expect that, in the traditional roundabout way of asking questions, they'll probably give you a little brief description of a submucosal leiomyoma, and that'll be answer choice A. And then they'll give you a little description of subserosal, and that'll be B. And then intramural, and they're not going to straight up say the words. They're going to go about it, again, in a circumnavigating way. So I could see that being a question. I am pretty sure you're going to get a risk factor question about leiomyomas, and I'm pretty sure you are going to get a genetics question about leiomyomas. And so then if there's 5, I would say the last question would probably be something about a clinical scenario, maybe a peritoneal invasion of a tumor, maybe a metastasis of this tumor. I would like to start with the leiomyosarcoma because there's just less material to cover there. So smooth muscle, invasive tumor. Because it's invasive, you see a lot of hemorrhages. The tumor's just going straight through, like taking a lawnmower to some vasculature. There's your hemorrhage. Necrosis, why? Well, going back to principles, what's some basics that we know about tumors? Well, they don't really do aerobic respiration. They do anaerobic metabolism. They do the glycolytic pathway, and they send that pyruvate to lactic acid instead of to acetyl-CoA. And so because tumor cells do this, they generate an acidotic environment, and non-tumorous cells really don't like that, and they die fairly quickly if you put them in a low pH. That's the same thing that exercise does, but because exercise generates lactic acid, and that's just a bunch of protons. But the thing is, you've got a good blood supply to this area that washes out all that lactic acid, and then your body's also got mechanisms to tell you, hey, dummy, stop exercising. You're getting too worn out, you're too fatigued. And so the tumor doesn't stay like that. You know, the tumor's always making acids, lactic acid. And so when you have a tumor in a given part of the body, it's like you're working out that part of the body 24/7. And so lactic acid is just trash. And so cells are just drowning in that low pH. So that's a big part of necrosis in tumors. Cellular atypia, nuclear atypia, and mitoses. These are kind of challenging to spot, but once you get good at seeing them, you can't unsee them. There's a mitotic figure. There's a mitotic figure circling in green here, and these are, of course, labeled by the arrows. That's a pretty big nucleus right there, uncharacteristic of a smooth myocyte. And in this image on the right here, zooming in, here is a big weird nuclei square in the center. Here's a couple of them next to each other. Kind of look like a binucleate Reed-Sternberg cell, you know? So hard to make the call versus a normal leiomyoma, but they should give you some sort of words in the questions to guide your differential towards the sarcoma. So some other important factors. These leiomyosarcomas tend to be solitary tumors. That's really important because in 2/3 of all leiomyomas, benign tumors, you see multiple tumors. So the fact that it's just one big, large, alone tumor already predisposes you to think leiomyosarcoma. Now, less circumscribed, that's kind of a given because the sarcoma is an invasive neoplasm. Less trabeculated or whorled, and those are just buzzwords that tell you you're dealing with a leiomyoma on histology. Absolutely, you see necrosis and hemorrhage with an invasive cancer. The distinction between benign and malignant smooth muscle tumors is established by three things: cytologic atypia, tumor necrosis, and mitotic activity. So they are going to give you probably two, if not one, of these three things in the stem of the question, either with words or a picture, and it's going to be an easy diagnosis. Finally, a finding of more than 10 mitoses per 10 high power fields. I don't know, but with all this urinalysis, you know, we've been seeing a lot of high power fields in question stems lately. So 10 per 10 here. Genetics, there are 3 genes you might want to know for the leiomyosarcoma. Understand the genetic changes that we see in the sarcomas are different than the genetic changes that we see from benign leiomyomas. The vast majority of leiomyosarcomas are de novo, and they don't evolve out of leiomyomas. They're just entirely separate from them. So 2 genes that you'll see mutated in the sarcomas that you won't see in the benign smooth muscle tumors are P53 and MIB1, men in black 1, right? And that MIB1 especially is going to be our go-to answer choice if we get asked about genetics. It's in 90% of uterine leiomyosarcomas, it's mutated. And one more, the P16 gene. You know, P16 inhibitor kinase 4, you know. So 3 genes there. Clinical correlate, because it's invasive, it might seed the peritoneum. So that would be, what's the word, you know, like direct encroachment or cavity seeding. You know, it's not a hematogenious spread is essentially what I'm trying to say. But they can metastasize hematogenously to the lung. Leiomyosarcomas have a very poor prognosis, and death often occurs within 2 years of diagnosis. So that's the leiomyosarcoma, not a ton going on there. Take a look at some photos quickly. Here's a benign leiomyoma, and see multiple nodules here, you know, multiple different foci of expansion. And each one actually represents a different cell of origin, you know. There's a singular leiomyoma. Not a lot of hemorrhage, a little bit bloody, but like not enough to where you would really call that hemorrhagic. It's a bland, gross appearance there. Same thing here, very smooth, clearly non-invasive, well encapsulated. And here's where we start to get into the leiomyosarcoma. That's a bloody organ right there. And you can tell that the interior, or kind of the core of this nodule, is a little golden brown compared to the tan, creamy outside. And so that's representing a little bit of necrosis going on there. Here's another leiomyosarcoma, and this thing is blown up, yo. So histologically, Here's a Leiomyosarcoma. We've got high degree of atypia down here to the bottom right. We've got some very condensed nuclei here. Not even sure. These two right here look like they might be actively undergoing mitosis. And then a little screwy figure there in the middle too. So it's not easy per se to make the call between a leiomyosarcoma and a leiomyoma, but with the gross appearance in addition to the histology, all of us should be able to do it. One more example here. Again, most of it looks just like a leiomyoma except for this part here in the middle. It's got some dark, really dark hyperchromatic nuclei that are very elongated compared to others in the plane. So getting up to the leiomyomas now, this is the benign uterine smooth muscle tumor. Presents in a couple of ways, two key ways, maybe with some overlap. Pelvic pain is one way, maybe it just hurts all day, constantly, you know, an ache. And the other is abnormal uterine bleeding, which may or may not present with an anemia, an iron deficiency anemia. So the uterine leiomyoma is the most common gynecologic tumor. It's estrogen dependent. How do we know this? Because after you go into menopause, these things shrink, they go away. Also, something very important is that if you ever hear the term fibroid thrown around, fibroid tumor, uterine fibroid, we're talking about smooth muscle benign tumors, leiomyomas. That's the fibroids, uterine fibroids. So something I can absolutely see a question being about is uterine fibroids occur 3 times as often amongst African American women as they do amongst Caucasian women. The reasons for this difference are not known, but that is a pretty big significant risk factor. Talking about location, we've went over this, we've gone over this, we went over this, and of importance is that if you see symptoms of abnormal uterine bleeding or pelvic pain, and you got to go to Vegas and play odds, it's probably a submucosal leiomyoma. Those are most commonly symptomatic, but they only account for 5% of leiomyomas. So if you get shown a picture of a leiomyoma and no symptoms are mentioned, and you got to take a guess, you're probably going to assume it's an intramural leiomyoma. You could assume that just by looking at the picture, couldn't you? You know, that's going to be the test question. I hope you can. So dysmenorrhea, what's that? Pain with a period. What am I looking for? Menorrhagia. Menorrhagia. So menorrhagia means excessive bleeding. Metrorrhagia, like young Metro don't trust you, means intermenstrual bleeding. So between periods, you get some irregular bleeding. So the timing's off. Menorrhagia means it's a heavy volume. Metrorrhagia means it's an abnormal timing. And then dysmenorrhea, again, means pain during the bleeding. Scrolling back up, multiple fibroids. These things travel in packs. Well circumscribed, encapsulated, tan, creamy appearance, no hemorrhages. In about 2/3 of women with fibroids, multiple myomas are present. Here's the histologic appearance of one. Notice really some dark nuclei, yeah, but no abnormal mitotic figures, nothing big and blown up in either of these two images. So some ischemic necrosis in this one image of a leiomyoma. Let me go green for that. And how can you tell? Because there's red blood cells just all up in between these smooth myocytes here, you know, because here's the capillary. Like right here is where a capillary is, and then here's another capillary, but then everywhere else you can tell like that's an abnormal presence of blood cells. Like you should not see blood cells in between individual myocytes like that. So these things can degenerate, and not sure what they would want to ask you about them. And I know that if they just gave you the names of the types of degeneration, well, okay, there's 5 of them, so we might get a question about this, but look at what they're called, y'all. Hyaline degeneration. Oh, I wonder what you're going to see in that, you know, collagen all over the place. Of course, of course. Myxoid degeneration. What could that look like? It's like just a bunch of extracellular matrix with glycosaminoglycans. We've seen that before a lot. Red degeneration. Say no more. It's red. Got it. Cystic degeneration. It's like another one, you know, there we go. And then calcification. It's like, hey, yo, I love it when we just name things in a utilitarian manner, you know, just the most functional way possible. It's not called, you know, Wade's degeneration, you know, or like, like Da Vinci's degeneration. No, it's called cystic degeneration. Why? Because that's what it is. It's like, let's do more of that in the future. So something else I underline, because when I see 4 or 5 of something, I see a test question. 4 major symptoms of leiomyomas that are indications for intervention. So question stem is like 29-year-old African-American female, like G1P1 comes into your office for a routine examination. You palpate a uterine mass kind of around the cervix. And so you figure out it's a fibroid tumor, and maybe she's got one of these 4 symptoms, right? And so then it would be like, which one of these qualities is a factor, is a reason for taking the tumor out? And so you would have to say something like abnormal uterine bleeding. Easy, done. Or like pressure on adjacent organs. Yes, done. Okay, take it out. So we get to AUB. So abnormal, what does that mean? That means too much at once, a heavy volume, that's menorrhagia, or maybe too frequently, that's metrorrhagia. So why would that happen in this leiomyoma? If you had a leiomyoma, why would you get abnormal uterine bleeding? And we're theorizing that there's a dysregulation of vasoactive growth factors in response to having a tumor in the wall of the uterus. And leiomyomas are going to make a ton of growth factors. They're quickly growing cells, you know, they've got these mutations that give them a competitive advantage over other cells. That's what cancer is. And so one of those potential advantages is that they could just start producing growth factors autonomously without needing other growth factors to do so. And so if that happens in the leiomyoma, 2 of them that they particularly like to produce are BFGF, basic fibroblastic growth factor, and our old friend PTHRP, which can be a cause of hypercalcemia. So these 2 growth factors, if they get into the surrounding non-cancerous endothelial cells and smooth myocytes, well, then they could cause venular ectasia. What's that? Well, it's not arteriolar, it's venous, right? So we're dealing with small veins here. And then ectasia. What is an ectasia? Remember that word means dilation. And we remember that because, well, a telangiectasia, what's that? It's this little thing on your skin that's kind of got a core, and then it goes like that outwards. And what's a colloquial name for that? Do you remember what else this thing is called? Here's a hint. You see it in cirrhosis, and you see it in situations of estrogen excess. It's called a spider angioma, right? So the other name for that is the telangiectasia. So tele, meaning like end, like the means to the ends. Well, the Greek word telos, that's where that comes from. And then angi, vessel, blood vessel, and then ectasia, dilated. So the ends of those blood vessels are dilated, and that's why you see the spider angioma on the skin. So in the case of that example, they're dilated because estrogen's got a little bit of a vasodilating effect, and it also raises blood pressure. But in the case of the uterus, when you've got a leiomyoma, you're going to be dilating blood vessels because of the presence of PTHRP and BFGF. So that dilation of blood vessels just means that when it's time to bleed, you bleed more, and sometimes you bleed more often. And so there's the AUB symptoms. Pelvic pain, common symptom, you understand that, you'll recognize that. The patient will literally say, hey, here's where it is. Pressure on adjacent organs, such as the sigmoid colon, right there, you know, constipation leading into that, and then bladder, possibly incontinency. Easy stuff, easy stuff. Only way they trip you up with one of these questions is maybe they say like, well, what's the nerve responsible for referring the pain from da-da-da, you know, or what's the nerve that's getting compressed? And then you're like, Let me think about that for a good 5 minutes. So fibroids are thought to be responsible for 2 to 3% of cases of infertility. And again, remember that the submucosal fibroid is the one that tends to present symptomatically the most, and it's also the one that's most responsible for infertility. So if you get asked, what is a complication of this patient's leiomyoma or leiomyomas, because they tend to be multiple, then infertility is a great answer choice. Great answer choice. But if that's not on the list, you want to go down one paragraph farther and look at these here. Miscarriage, antepartum hemorrhage. That's not good. You don't want to bleed too much before you deliver. And if you bleed too much during delivery, that's also very bad, because then you'll have to get a transfusion, and then there's a slight risk of a reaction there. And then it also puts you at risk for Sheehan syndrome, remember, postpartum pituitary necrosis. And finally, increased risk of preterm labor and delivery. That's pretty noteworthy, because there are some conditions off the top, the number one being neonate respiratory distress, that are enabled by premature birth. So how do you diagnose these things? There is a good section on this with a couple of good pieces of information, so I wouldn't rule out a diagnostic question. MRI is the gold standard. Ultrasound is going to be your first imaging modality, most likely. And you can catch a lot of these just on manual physical exam. Risk factors, definitely thinking we'll see a question from this. So number one, if you're African American, you're 3 times more likely than any other ethnicity in the world to get fibroid tumors of the uterus. Number 2, age. They're age dependent, but it's not linear. It goes up and it goes down after menopause. Why? Because these things are estrogen dependent. Number 3, parity. Also related to estrogens, when you're pregnant, you've got a lot of progesterone. So I learned this today. Catch this, Passio. So progesterone, progestation hormone. Oh my word. You know, it's like the air horn that plays on like those like 2009, 2010 like Waka Flocka songs, like it's like I heard that and that just went off in my head. I was like, everything makes sense now. So progestational hormone, what does it do? It antagonizes estrogen and it shuts down GnRH. Why does progesterone shut down GnRH? Because you're not having a period if you're carrying a baby. That's the last thing you want. You know, like, duh, of course. And so what else does progesterone do? Well, it makes a lot of mucus within the uterus, because you're going to want to stop more sperm from getting in there, because you don't need another baby. You've got one already. And if you don't have the baby and you don't have the implantation, the corpus luteum just goes away. And that's the thing that's making progesterone throughout the first trimester. So you need something to stop subsequent implantation episodes. And so that's why GnRH goes down. You turn off follicle growth, you turn off ovulation, and then you get the mucus there because you're going to block polyspermy too, you know. And so it's like, and then progesterone is also going to oppose the effects of estrogen on the endometrium. So estrogen encourages endometrial growth and proliferation. But when you're implanted, you could say, no, we can slow down right now. We don't need to grow the endometrium. We've got to focus on the placenta now. So it's like, that's something totally unrelated. And so progesterone, progestation hormone, is going to mediate all these effects. And so when this paragraph right here is talking about if you're never pregnant, you've always got unopposed estrogens, it's not saying that. What it's trying to convey is the inverse of that. When you are pregnant, the effects of estrogen on the body are opposed by progesterone, which is going to shut estrogen down. So for the 9 months that you're pregnant, estrogen is not exerting as strong of an effect on the body. So these estrogen-dependent tumors, when you're pregnant, do you have a more or less risk of getting an estrogen-dependent tumor? Probably less, because estrogen's being opposed by progesterone when you're pregnant. So having kids is protective against uterine leiomyomas. That's where that whole paragraph is going. And then obesity, that's a risk factor. And you should understand by now that the more adiposity you are carrying around on your body, the more aromatase you have, because adipocytes express the enzyme aromatase. And what does that do? Well, it takes an androgen like DHEA, and it just flips it into estradiol or estriol or one of those 3 different estrogens. So the more fat mass you have, the more estrogens you have circulating around in your blood. And those other risk factors, I mean, if it's E through H on the list, forget about it. So genetics. Okay, 70% of leiomyomas are going to express a mutation in this MED12 gene, the mediator complex subunit 12, which is involved in regulation of RNA polymerase II complex. So what's a polymerase? It's a polymerase. Anything that's an ace binds things, links things, ligates things. So a polymerase, well, what's a polymer? It's just something with sequential homology. It's got a conserved structure to it. So an RNA polymerase just makes long RNA chains. And so if you're just able to make RNA all day long, can you see how that's going to be very beneficial to the growth of a tumorous cell, cancerous cell? It's going to encourage its growth. 40% of leiomyomas have this 12-14 translocation in which HMGA2 gets overexpressed, and that's all you really need to know about that. And finally, these tumors are estrogen sensitive. Brought this up before, just in case you missed it. Leiomyomas are monoclonal proliferations if multiple tumors in the same uterus are found, each is clonally distinct. So that means that if we're looking at this example of a leiomyoma, then this, you could say this is tumor 1, and then this over here would be tumor 2, and then you'd have tumor 3 right here, and tumor 4, and so on and so forth, and each of these different foci would be from a different cell of origin. That's about all I need to know about this nice, brief 10 or 11 page SDL. Thanks.